What do you say to a 28-year-old woman who's having hormone imbalance, who comes across this podcast and is like, do I really need to listen to this particular podcast? I'm only 28. I haven't had kids yet.
I say it's never too early. It's never too late. But I think switching to that to the younger generation, it's never too early. And this is something that when I was preparing for birth, I was doing it with the intention of trying to avoid what my mom went through, because she did share some stories with me about her birth experience. And I was preventive minded. That was not what I was witnessing. When I started my business, I was working primarily with pregnant women and new moms who were also not of the mindset of preparing. They thought, this isn't going to happen to me. Basically, they didn't have a problem to fix. I don't need that information.
Hello, it's Healthy Gut Girl, Kitty Martone, and this is stuff your doctor should know. And I'm coming to you live from deep inside your vagina. What? Yes, I am deep inside your vagina with Kim Vopni. For those of you who don't know who Kim Vopni is, you need to learn. She is the Vagina Coach. And if you aren't following her on Instagram, you need to be. She is a pelvic floor fitness and women's health coach. She helps women prevent and heal incontinence and prolapse, which I think is really just does not encompass the full value of what she actually gives to women. She has incredible method of teaching women. It's called Buff Muff, of teaching women about pelvic floor integrity and optimizing pelvic floor health. She also has great videos on Instagram. I don't know, she's probably on YouTube as well. Again, it's Kim Vopni, and I learned so much. She also has a really cool podcast called Between Two Lips, which I think is, the puns are endless. It's so much fun. And she is here today to talk to us all about A to Z pelvic floor health, and I hope you enjoy it. I want to kind of start from the beginning. My group used to be just like perimenopausal women. We were like 5,000 women at that time. Now it's like 26-year-old whose doctors are telling them they're going through perimenopause.
Wow.
Like it is young women. And so I want to kind of start there, because I know a lot of the listeners are going to be like, what does this have to do with me? What do you say to a 28-year-old woman who's having hormone imbalance, who comes across this podcast and is like, do I really need to listen to this particular podcast? I'm only 28. I haven't had kids yet. What do you say to her?
I say it's never too early, never too late. But I think switching to that to the younger generation, it's never too early. And I think this is something that when I was, like, from a pregnancy perspective, when I was preparing for birth, I was doing it with the intention of trying to avoid what my mom went through, because she did share some stories with me about her birth experience. And I was preventive minded, and that was not what I was witnessing in my friends. When I started my business, I was working primarily with pregnant women and new moms who were also not of the mindset of preparing. They thought, this isn't going to happen to me. Basically, they didn't have a problem to fix. So I don't need that information. And I think that's true of the world. When we have pain, when we have a problem, when there's something that's presenting itself as an issue, we are motivated to change something to overcome that. When that problem doesn't exist, and we've only heard that it could potentially happen down the road, it's not a pain point for us. So we aren't invested in putting in the effort to prevent it from happening. We're much more of a reactive society, I would say. Just human nature is that way. But if we can switch the mindset to look ahead as to what could potentially happen and what is probably going to happen when we think about perimenopause and menopause, if we can take steps earlier to change our diet and lifestyle, optimize our pelvic floor health, prioritize our sleep, like do all the things, it will set us up for that transition period to be easier. But also in the grand scheme of things, it's better for our overall health in general. Mm-hmm. And this is the only body that we have to live in, and we should make it as best of a place to live in. That's not very good English, but we want to optimize this house that we live in, right? Mm-hmm. So that everything else in life becomes easier to manage. Mm-hmm. When we have to manage, you and I, before we started recording, we were talking about our parents. And I'm witnessing my parents now. They will both be turning 80 this year. And the difference between my mother and father, my mother was not necessarily super proactive in a sense, but she's always been very active. Whereas my father, definitely not proactive and very sedentary. And the differences between the two of them are are significant. But I'm also witnessing the two of them being more of the reactive mindset and where they are now versus what I'm envisioning for my future. So this is extra motivation for me, witnessing what is happening to them based on their choices and decisions of where I'm going to choose a different path and make different choices and decisions earlier, but also arm myself with that information. So I would say get informed and take action. Don't wait for there to be a problem to overcome.
Yeah, that is so good. And you're right. My mom, exactly. Before I did hormone stuff, before I was in the hormone space, I was healthy gut girl mainly. I was doing gut stuff and for years. And I was continually trying to tell my mom, like be proactive with your digestion, be proactive with how you digest your food, with all of that stuff. And sure enough, she didn't until it became an issue. And then now, of course, she's dealing with emergency situations that
Yeah.
I think could have been prevented. And so that's really well said. And also, what about women who are like, I'm not going to have children, so I don't need to worry about this? Because I didn't ever have children. I dealt with the infertility thing. By the time I learned everything that I know now, it was a little too late. So I feel the same way about the whole pelvic floor health, as you say. If I could go back a little bit, even just to address this more, because I'm only just addressing that because I thought, well, I don't have children, so I'm not going to have to deal with that. What do you say to that, to women who are like, yeah, I'm not going to have kids, so I don't need to worry about that?
It's a big myth that pregnancy and childbirth are the only reasons why somebody would have pelvic floor dysfunction. But you don't ever have to have been pregnant. You don't ever have to have given birth at any point in your life to experience stress urinary incontinence, pelvic organ prolapse, pelvic pain, painful sex. Yes, a contributor. It's a well-established contributor and an increased risk if you have been pregnant, if you have given birth. But for people that haven't, they are sometimes even more surprised when they have this issue because they think, well, I haven't given birth. And that's what they have associated with the only contributing factor.
Yeah.
And so, again, I wish, it is my hope that sometime in my lifetime, we have changes potentially even in the school system where when we are teaching our kids about menstrual cycles and bodies and sex, and it's very focused on don't get pregnant. It's birth control is the main purpose in some regards. But if we planted a seed at that point that we have this incredible group of muscles called the pelvic floor, whether you have male or female anatomy, females menstruate. Many females do become pregnant, but not all. And everybody, if you're making it to midlife, will go through menopause. And these pelvic floor muscles have really, really important jobs in the body: pelvic and spinal stability, organ support, continence, sexual response, sump pump actions with the diaphragm. If we were told this information earlier, if we were told the common signs and symptoms, if we were told about pelvic floor physical therapy and pelvic floor exercise, and what is kind of normal and what is not normal, then the seed would be planted for people to know who to go to, know what questions to ask, know that it's not something they just have to put up with or just part of being a woman. So if that education happened earlier, I feel like it literally would change the world and change the trajectory of women's health.
Yeah.
So for people that have never been pregnant, who never plan on becoming pregnant, you still have this group of muscles called the pelvic floor that have all of these incredible jobs that I've just listed. And with the hormonal fluctuations of our menstrual cycle, with age-related muscle loss, with changes to our bone scaffolding, if we are reaching midlife, all the changes that are sort of precipitous because we have now reached this point of we're in this low estrogen state or even low hormone, all hormone state for the rest of our life. Again, let's not wait, knowing statistically upwards of 80% will experience symptoms of what's called genitourinary syndrome of menopause. So it used to be this term called vaginal atrophy, which was associated with postmenopause. And it was a not a great term. Nobody wants to think of things being atrophied, but it also wasn't encompassing of all of the changes that are happening. So there are genital changes to our external, to our labia, around our clitoris. There are sexual symptoms. There are urinary symptoms, urgency, burning, frequency, stress urinary incontinence, increases with pelvic organ prolapse, painful sex. Like I can go on. There's a whole host of them. And upwards of 80% of women will experience this.
Wow.
And it doesn't just happen right away at menopause. It can take years. So it's usually like 7 to 10 years post menopause when, if they haven't started already, things are definitely showing up at that time. So again, if we know those statistics, let's not wait to see, well, maybe I'll be one of the ones it doesn't happen to. Let's be proactive, knowing that the majority of women will, and it's probably going to be, and take the steps earlier so that we prevent. Like, I'm not interested in suffering, and I feel like a lot of people just accept that they should suffer. And
I'm
that's a
old.
big message with,
Yeah.
yeah, a big message with the perimenopause, menopause transition, is that it's going to be all this suffering and we should just accept it. We're often told by care providers that that's just what happens. And thankfully, the world is, a lot of very influential women are standing up right now saying no, and they're educating about menopause now. And I am seeing the trickle effect to the younger generation, because kind of like as I'm witnessing in my parents, I'm not interested in what's happening there. So I'm going to do everything I can to change my trajectory. And I see that now shifting into the younger generation, looking at what this conversation around menopause is. They are going to be much more informed earlier on, and then it's up to them to take action.
Yeah. I mean, we already are, like you and I are already, compared to our parents, and then, the next generation. Something we do a lot, I think, is we just compartmentalize what was the word you use? It's urinary.
Genitourinary syndrome of menopause. Yeah.
Yeah. So genitourinary system, we really compartmentalize that away. Like
Yeah.
everyone, well, in our circles, like when I'm looking at the pro metabolic community and all the Instagram influencers and everybody talking about the markers of thriving, the markers of longevity, hand grip strength, quad strength, toe strength and ankle strength, and how these markers of longevity are important to focus on. And we kind of don't talk about that whole compartmentalized area. But I mean, it sounds like it is directly, in fact, I don't think you can work on those things and ignore that area, ignore that genitourinary area, because I mean, I guess you could tell me about that, because sometimes people will say, I want to know, like, the correlation between lower back pain and pelvic pain and painful sex. Two totally different things in their mind. Like that one has nothing to do with the other. Like, oh my God, my lower back is always in pain, and I happen to have painful sex too. They don't think about those two being related, right?
Yeah. Yeah. Yeah, an interesting stat just on that point, and then I'll answer kind of the bigger conversation. But 95% of women with low back pain have some form of pelvic floor dysfunction. And we will go to a massage therapist or a chiropractor or get acupuncture, see a regular physiotherapist. And all of those can absolutely play a role in managing that. However, the missing link is so often the pelvis. And so when you see a pelvic floor physical therapist, it is, so many people come away with their mind blown, and they say, how can I have lived, 40, 50, however many years in this body, and I didn't know this, or I wasn't aware that I was doing this in my body. So I think it's one of the most underused women's health resources that we have. And if people were to take away one thing from this episode, I would say find a pelvic floor physical therapist and make it part of your care team. And you see them once a year, just like you see your dentist for a checkup. Back to the point about the longevity piece, I think this is something that has really become a profound part of my messaging in the last 3-ish, 5 years, so to speak. Part of it, witnessing my parents. Part of it, my own now post-menopause, my kind of perimenopause, now post-menopause journey. I started my work with pregnant women, and my intention was to help them understand what the pelvic floor is, what they could do to train for birth, how they could reduce their risks of tearing, how they could more favorably recover, and how they should focus on recovery. That's something that we don't necessarily focus on here. And that was kind of my world for a long time, prenatal, postpartum. And then when I started to go through my own perimenopause journey, I started to have my own pelvic floor struggles as well. And I said, this is not just a do your Kegels in pregnancy and here's how you recover. This is a lifelong journey. And there are many people who never go through that prenatal postpartum who are also now struggling.
Mm-hmm.
And so that became part of my story. But then on the postmenopause side, how many women have come to me who have osteoporosis, who have diabetes, who have metabolic disease? And a big reason or a big contributor has been the fact that they have not exercised, they have been constipated. And as a result, like they have not exercised because of their pelvic floor. Sometimes they've even been told not to. Oh, you have a pelvic organ prolapse. You can't lift over 10 pounds for the rest of your life. I consider that BS, just as a sidebar. Don't run, don't jump. All the things that are going to benefit our bones, women are either self-removing themselves from because they think it's going to make their pelvic floor situation worse, or they've been told to. So now, especially post-menopause, when we lose an incredible amount of bone mass in our first 5 years post-menopause, 10%, when we think of how many people are struggling with constipation all through that perimenopause journey, that can sometimes be pelvic floor related, but sometimes gut related, other conditions. But that is also then going to strain the pelvic floor and lead to other issues. When you're constipated, first of all, you don't feel great and you're straining. So you're going to put more pressure on the pelvic floor. You're also going to have more symptoms of urgency and frequency. And then people are dealing with urgency and frequency. And then they're saying, well, I don't want to leak and I don't want to have to find a bathroom. So I'm not going to drink any water. They think that's a good strategy. So now they're becoming dehydrated. Now they're going to be even more constipated. Now they're not getting the toxins out of them. And they just get into this vicious circle that at the end of the day is harming, not just like they think they're protecting their pelvic floor, but they are, I would argue, harming their health span, their longevity. They aren't getting the impact to the bones. They are dealing now with insulin resistance. They're not getting the toxins out of their body. So, of course, I'm biased, but the pelvic floor we have to address the pelvic floor. And if we can, again, have this information earlier in life and keep it optimized, we aren't going to be dealing with these situations. And we are then primed to be able to do all the things that we need to do to maintain our muscle mass, to maintain our bone health, to avoid diabetes, to avoid cardiometabolic disease. So in my opinion, it's like one of the most essential overlooked parts of longevity is the pelvic floor.
Mm. You said something that triggered a thought of the strain. Could hemorrhoids, now, being healthy gut girl, I've always had my own thoughts on what is the root cause of hemorrhoid issues, but could one of them be ongoing pelvic floor dysfunction?
Yep. 1000%.
Just the strain.
Yeah. And if you have, so oftentimes, like we think of constipation as I need more fiber or I need more water. Like we think that is going to resolve all constipation issues. And as you know, there's many other contributing factors, but one of them is pelvic floor dysfunction. Wow. If you have pelvic floor muscles that are not able to relax, so when we void, whether it's urine or feces, we need the pelvic floor to relax so the bladder can contract or so the rectum can void. And if we have muscles that are tight or non-relaxing, that are holding on to too much tension, we are needing to strain and we're not getting the appropriate response from the pelvic floor. So we don't get complete emptying. We have to strain. We feel like we have to strain. And so again, if we can address the pelvic floor, if that is one of the contributing factors, and we should check it out, releasing tension and getting the pelvic floor working better will then allow us to poop better without having to strain.
I've never thought of that potentially contributing. And so what are the different things that can go wrong? So you've mentioned pelvic organ prolapse. What about like the rectal prolapse? I know there's 3. I was watching some of your videos and listening to some of your podcasts, which by the way, everybody needs to subscribe to your podcast. I think it's one of the best podcasts because it doesn't just cover this. You cover hormones and health, metabolic health in general. And so side note, thank you. And so pelvic organ prolapse, rectal prolapse?
A prolapse is where the bladder, the uterus, the rectum, in some cases the urethra and the intestines will shift out of their optimal anatomical position, and they start to bulge into or descend into the vagina. So in the case of a bladder prolapse, it can also be called an anterior wall prolapse. It can also be called a cystocele. And this is where the bladder bulges into the front wall of the vagina. In the case of a uterine prolapse, the uterus can descend from the top down into the vagina. And in the case of a rectocele, different from a rectal prolapse, a rectocele is where the rectum bulges in the back wall of the vagina. So it can be called a rectocele or a posterior wall prolapse. A rectal prolapse is when the rectum bulges out the anus, and that's something that can happen in male and female anatomy. And a lot of women who have a rectocele call it a rectal prolapse. And again, we've never been given wording or education about this, so we don't even know what's happening in our body. And unless we have been seeing pelvic floor physical therapists, we don't know. And just sidebar, if we get a pap exam, a lot of people say, well, I see my OB-GYN now year and I have a pap exam. When a speculum is put in and cranked open, it pushes those bulges away. You may see a descent of the uterus, the doctor may see that. But unless the person has come suggesting they have symptoms, the doctor typically won't say anything. Again, we have a very short window of time. Their purpose is to scrape the cervix and look, but unless the person is presented with bothersome symptoms, the doctor won't typically say, because they don't want to create an issue that's not there. However, I look at that and say, well, we have an opportunity to step in early and prevent that from becoming a major issue. So please tell if there is something that you see that is not accurate. So that's what happens in a prolapse. It's a shift in the position. And early stage prolapse can be asymptomatic. You feel nothing. There are some people with really advanced prolapse that have no symptoms. There's some people with early stage prolapse who have crazy symptoms. So symptoms are not an indicator of severity. And this is another reason why I suggest we see a pelvic floor physical therapist once a year, even if we have no symptoms, because they can screen, just like our dentist screens for issues in our teeth. We go even if we don't have a toothache, because we've been conditioned to do that. And then we brush and floss until we go back. And if they say we don't have any issues, we don't stop brushing and flossing. We carry on with our maintenance routine until we go back. And I think we should do the same thing with our pelvic floor, because if we catch prolapse early, we have the potential to definitely prevent it from getting worse, improve it, potentially even reverse it. With bladder and uterine prolapse, if caught early, very likely that you could reverse that. Rectoceles are a little bit trickier. Mm-hmm. Again, without this information, little subtle symptoms that will either no symptoms, but then subtle symptoms. And then especially, they will be getting worse. It can be progressive over 20 years. And then all of a sudden one day people have this bulge at the opening of their vagina and they start to freak out. And a lot of people think it's cancer. They get very scared. And this has been a progressive condition that had we caught that earlier, we would have been in a better position to manage it, really. Mm-hmm. So that's what happens in a prolapse.
So does a pelvic specialist, therapist, if you will, do they physically check you?
Yes. So pelvic floor physical therapists are regular physical therapy, or if you're listening and you're in Canada, it's called physiotherapy. It's the same profession, slightly different nomenclature. Australia is often physiotherapy. Europe is often physiotherapy, but women's health or pelvic health, physio or physical therapy, are trained as physiotherapists or physical therapists first. Then they take additional training in the pelvic floor that provides them a license to evaluate and treat beyond the opening of the vagina and potentially the anus as well. So wow. There is kind of a whole body. They take your health history, they look at your posture, they look at your breath, they look at movement mechanics. They obviously are taking account into what brought you there, what symptoms you're dealing with, if any. And not always on the first session, but with your consent, there will be an internal evaluation, which is with gloved fingers. And that they look at the external genitalia. They look for skin changes. They look for if the person has any scar tissue from childbirth, from previous surgeries. They then do an internal evaluation. So one finger would be inserted. They will see if a second finger could be accommodated. They will be noticing any if discomfort that that person is feeling. They want to check for the sort of the balance between the two sides. So sometimes we may have more restriction or tightness on one side of our pelvic floor compared to the other. We should have a balance in tone. We should be able to, with the fingers inserted, they will ask you to do a Kegel or your interpretation of a Kegel.
Mm-hmm.
And they should feel a hug of their fingers and a gentle drawing up and then a release. They will look and feel for the position of the organs. They will ask you to cough or bear down to see if there's any descent. A great therapist will also assess you in standing because things are much different lying down on a table versus upright against gravity. And they can even assess you doing something like a squat. So this is really valuable information, especially in the asymptomatic person, and why we benefit from this check. Because then if they notice you have a bit more tension here, or if they notice there's an early stage prolapse, we can look at what are the root causes and contributing factors and what can we change. Maybe it's your posture. Maybe it's the way that you breathe during your squat. Maybe it's constipation. Maybe it's low hormones. And we can look from this root cause investigation, and you then take those steps to prevent that from getting worse and most likely being able even to reverse it.
Wow. Okay. A lot of women who are having discomfort with sex, discomfort in any way having to do with their vagina, they're just uncomfortable. You know, we talk about inserting progesterone suppositories and they're like, it's so uncomfortable. Could those things worsen if you have a condition? Could having sex worsen it?
I mean, so sex is ultimately beneficial for the pelvic floor. With or without a partner, insertion or not, orgasm is good. Insertion is beneficial. Again, it doesn't have to be a person. It could be a toy or something. However, if somebody has like potentially a negative first experience, there can be resulting tension in the pelvic floor from that negative first experience. And unless we address that, it could forever be an issue, and maybe that would get to the point where insertion is not possible, or even just the thought of insertion or touch becomes a challenge. So I wouldn't say that if you have a challenge, if it feels uncomfortable and you don't address it, that it's absolutely going to turn into something bigger and worse. I'm not going to say that will happen for everybody. However, if their sex should not be painful, touch and insertion should not be uncomfortable or painful. And if it is, that's a message your body is saying, please help. And I would say, go see a pelvic floor physical therapist to look at why is that happening?
Yeah.
And it could be because of tight muscles. It could be from scar tissue. It could be from the position, like the position of the organs, and then the position of the sexual act or activity. Sometimes different positions. If somebody has a prolapse, maybe the descent of an organ is in the way and that's creating some discomfort. And we don't know unless we have somebody help us understand.
Got it. So, you know, it's because so many women, and I see this in the group all the time, regardless of their situation with a partner, marriage, whatever it is, and they have these aversions to sex, and they just are like, it's okay. I'm in menopause now, or I'm in perimenopause. I don't need to do it. I don't need to use it. I can just let it be. It's fine. I'm not dying to have an orgasm. All is good. If I just leave it alone, it's okay. I just want to stress, and maybe you can add to this, how it's also a marker of longevity to be able to have a sexual drive. It doesn't have to be swinging from the chandeliers. It can be just a sexual drive, to have a libido, to want to touch yourself, to want to have intimacy, even if it is alone or with a toy, is important. It is a marker of longevity. Would you add to that or agree with that? Yeah.
I would 1000% agree with that. In many cases, there are a lot of things that have got to the point where the person is, as you've said, I'm fine if I just don't touch it, if I just leave it alone. And that could be fear of leaking with sex. Or if they know they have a prolapse, what if my partner sees it or feels it? And so there's this we remove ourselves from the present moment. We aren't engaged because we are just distracted thinking, well, is my partner going to see it? Is it going to feel? Am I going to leak? What if I fart? What if I this? And so if we, again, optimize the pelvic floor, that those thoughts aren't even in our mind.
Right.
And if we are also receiving appropriate education and taking action for hormone management, these things wouldn't even enter our mind because we wouldn't get to the point where something has become uncomfortable. Or I don't want to take away from other conditions that can lead to discomfort. I'm talking more kind of this incontinence and organ prolapse and painful sex from low estrogen mainly. There are other conditions, vulvodynia, stibulodinia, so pain, pelvic pain conditions that sometimes are often not just pelvic floor related or because we've had a low hormone. There are other contributing factors. But
yeah,
oftentimes it's these other kind of distractions from our pelvic floor that have led us to the point where I don't want to think about it anymore.
yeah,
And if we accept that, then we're also not going to be paying attention and our symptoms will progressively get worse. We will have genital changes. The vagina literally can close. The walls of the vagina can become so atrophied and dry that insertion is not possible. We can lose our internal labia minora. They can shrink and literally disappear. The clitoris, we can have like adhesions around the clitoris. We don't need to accept this as just part of aging. Local vaginal estrogen, I consider an essential nutrient. I know it's not a nutrient, but I jokingly say that.
I'm excited to get to that because
okay.
So what about hysterectomy? Well, there's two parts to this. One is, are women that have had a total hysterectomy more likely to have any kind of prolapse?
Yes.
Okay.
This is well established in the research. Hysterectomy increases your risk of incontinence and pelvic organ prolapse, and nobody is ever told that.
Yeah. I mean, it only makes sense, right? It structurally makes sense.
But the other thing, and I just had a woman this morning message me saying she was dealing with urinary challenges. And she said, I've had a hysterectomy. I can't remember how many years. I think she said maybe 20 years ago. I don't remember exactly how many, but she said, I've had a total hysterectomy. So I don't have any reproductive organs to be making to be a challenge. And I said, well, you don't have your uterus, yes, but your rectum is still there, your vagina is still there, your bladder is still there. I was on a recent podcast recently as well, where I was saying that this is sort of a flippant offer. Doctors, like if somebody is heavy bleeding, which is very common in perimenopause, often due to low progesterone, heavy bleeding, fibroids, and organ prolapse are the three main reasons why somebody has a hysterectomy. If we caught prolapse earlier, or if we took action, we could improve that. If we gave people some progesterone and looked at root causes of heavy bleeding, same with fibroids. There are some cases where hysterectomy will be the best option. However, not always. So 9 out of 10 reasons for hysterectomy are benign conditions. And nobody is told that it increases the risk of incontinence and prolapse. So they think it's offered to them. They're like, well, you don't need your uterus anymore. Let's just take it out. And at the moment when you're have murder scene periods, or you're dealing with fibroids, or you have pelvic organ prolapse, you think, hell yes, please. I don't need it anymore. Take it out.
Yeah. And
many people who I work with say, had they known the repercussions and changes that happen as a result of hysterectomy, they would have made a different decision. So I don't want to take away from the fact that there is no shame in having had or needing a hysterectomy or choosing one. But please work with a hormone specialist. Please work with a pelvic floor physical therapist prior to your surgery, after your surgery. Absolutely see that person once a year, because now we have changes to the landscape. We have scar tissue that can interfere with muscle function. We're going to have some hormonal changes, most likely, even if somebody has left their ovaries. We know that they move into menopause quicker. And that space where the uterus was becomes now it's a void, and other things can start to shift in. Intestines is one. The top of the vagina can start to collapse in on itself. So we really want to make sure you ask your surgeon how they are going to reattach the top of the vagina, because the uterus and cervix play a role in helping keep our vagina held up in place.
Wow.
So no shame. It has happened to many people, but it's in your capacity to see your pelvic floor PT, use hormone therapy, and be very consistent with pelvic floor muscle training and all the lifestyle factors avoiding constipation, posture, all those things to help reduce that increased risk as a result of your hysterectomy.
And then the other part of that question is surgery for these types of things. I know there's different types of meshes, but I heard also that they're not very helpful, and there's a lot of failures with them. Can you tell us more about that?
My belief is this is not documented in research. There's actually, though, it's a couple of interesting pieces recently that I'll highlight. But my belief is that a reason why there is such a high recurrence post pelvic surgery is because the root causes have not been addressed. So if somebody has pelvic organ prolapse and they have, whether it's like a repair or they've removed the uterus, then the symptoms may be gone, but the reasons why that prolapse happened in the first place, often constipation, chronic coughing, poor posture, poor lifting mechanics, if those haven't been addressed, that person is all the same contributing factors are there. It's just a matter of time before it starts to affect another organ or potentially the same one, especially if that person is not doing pelvic floor muscle training, is not having their scar tissue managed, is not keeping their hormone levels optimized. So I'm a huge believer, and I went through a pelvic surgery myself, and I really struggled with this decision because I'm the vagina coach and I'm telling people all the things you should do to not go have surgery. And then I had a rectocele. So that's where the rectum bulges in the back wall of the vagina. And I lived with it for 9 years. And I very informed. I did all the work. I was seeing pelvic floor PT, did all the things, and I could not improve it. And it just got to the point where this was interfering with the quality of my life so much. And I wasn't prepared to wait until it was so bad that then it was an appropriate time for surgery. I wanted to take advantage of being younger, healthy, robust tissue so that, again, because I was starting to limit certain movements, I was starting to plan my life around, if I'm going to have a good bowel movement or not that day. So my life was becoming very small. And if I let that go forever and ever, then how many years would I have been missing out on life, right? So after 9 years, I did go through that. And I was so afraid to tell my community that I was making this choice. I had canceled my surgery twice. I finally went ahead the third time. I told my community, and I thought, oh my gosh, they're not going to believe, they're not going to trust me anymore. But it became a huge part of my business, was supporting people through surgery, because this is another, people feel shame, they feel embarrassment. Nobody tells them root cause investigation. Nobody tells them how to prepare. Nobody tells them how to recover. And I was looking at this as, I think there's a lack of information about pelvic health in general. There's definitely a lack of information about surgical interventions for pelvic floor health. And I think we could absolutely reduce those risks of recurrence if we were given the right information ahead of time to prepare, how to recover, and how to progressively get ourselves back to all the things with pelvic floor muscle training, posture, all the things.
And so that not only did it change the way that you teach and share your message, but your life didn't feel so small anymore. Now you've been able to work with that, and now you feel not small.
Yeah, it changed my life. It was a very good decision. Now, I went in very informed. I did all the work ahead of time. I share it on my blog. I share my whole prehab. I share my whole 6-week recovery. I share my journey back to lifting. I use pelvic floor physical therapy. I share all the things, and that is not the norm of what typically happens with surgery. People just are like, oh, I need surgery, and they wait for their surgical date. They have surgery. They go through their, don't lift anything for 6 weeks, and then they're given a green light, and then they're like, great, I'm fixed. And they go back to their daily life, which, again, I'm not saying that everybody has poor habits, but many people do. And many of the things they have been doing contributed to where they got to. And if we haven't made those changes, they're now, again, because of that scar tissue and change of orientation, they're at greater risk.
Okay, let's get into this now. We have a little time left. So I have a terrible reputation for demonizing estrogen, and that is just absolutely not true. It is absolutely not true. I am very much 100% lover of estrogen. I call estrogen the lion and progesterone the lion tamer. And me having crazy estrogen dominance my whole life and really digging deep kind of in the same way that you have with what you do, really understanding that it isn't about the hormones, it's about what you're doing with the hormones that matters. And so you can take any woman and give, this woman estrogen and this woman estrogen, and you're going to have vastly different, experiences. And so I always go with the less risky hormones first, which are like pregnenolone, maybe DHEA, and definitely progesterone before I venture into talking or even recommending testosterone. Or I'm not a doctor, so not prescribing, but just recommending testosterone or estrogen, especially in, premenopause. And so in my group, I'm always like, look, if you're going to do estrogen, definitely do it with guidance, definitely get checked, definitely test, periodically. Like it can go from bad to worse very quickly if you are not aware of what your body is doing with the estrogen. One of the key points is I did this crazy lab on myself, this 24 hours of blood spot, blood serum, dried urine, 24-hour urine, and then I did hair tissue and nail analysis on steroids and my steroid analysis. And I came back with very low levels. This was right when I went into menopause, very, very low levels of everything except in my hair tissue and nail analysis. I had 100 times more estradiol in my hair tissue and nail than I should have had. And so when I take estrogen, it's very clear. I might have benefits in some ways, and then in other ways, I have other issues. So I might have like vaginal dryness go away because I'm using estriol or estradiol vaginally. But then, I start to feel this cystic breast hardening of my breast tissue. And so I'm always like, let's just be super keen on these things. Just because we're in menopause, it doesn't mean, it might mean you have low tissue, low circulation estrogen and really high tissue estrogen. And that's not what we want at menopausal age. We don't want to be growing things in our tissues. So my group was like, we can't wait till you talk to Kim because Kim loves estrogen. So I was like, I'm not afraid of this. I know we are going to meet common ground here. So I am not against, in fact, I'm just 55. So I might end up using estrogen in 5 years or in a year. But what I know now is by boosting my metabolism, by doing a lot of things you talk about, I'm making hormones. They're not swinging from the chandelier hormones, but I'm making enough hormones that I'm not having issues with vaginal dryness and stuff like that. But I'm always like, start with the progesterone first. Use the progesterone vaginally, use vitamin E vaginally, use hyaluronic acid vaginally. Like, let's try to get as far as we can with these things before risking potentially using estrogen. Let's talk about the integrity of the vaginal walls, the vaginal canal, and how important it is to have estrogen in the vaginal, for that integrity, but also progesterone, right? The balance of the two, in my opinion, is what creates that integrity. What do you say?
Okay. So I want to just decipher or distinguish between local vaginal estrogen and systemic estrogen, systemic hormone therapy. So, and
Can I
local
say
vaginal hormone
Can I
therapy.
say
Yep.
really quick? Okay,
Yep.
so this comes up all the time. I just want to preface, I should say, that from my education and exogenous metabolism of anything that gets put on the skin, not anything, but hormones in particular, they go through second pass at the liver. They don't go through first pass at the liver, but they eventually have to make their way. That's how it works. That's why it works. Yes, estriol is weaker and it's not going to have the impact that estradiol will have when you put it locally. However, we need the estradiol, like we love the estradiol for vaginal integrity, but it does not stay local. Like it travels systemically. That's how come a patch works. That's how come any exogenous hormone works. So when you say it's local versus systemic, where does that come from?
So there's local versus systemic, meaning local is, and also to distinguish the dose. So if we were to use the same dose in a patch or in a transdermal gel that is considered the systemic, if we were to take that and apply it locally still, you could argue, transdermally to the vagina, yes, that is a bigger dose and more would be absorbed. The dose of vaginal estrogen, so applied to the external genitalia and inside, is significantly lower than the dose we would have systemically. And there is very little, if any, that is making its way elsewhere. That's why the typical estrogen dose for vaginal estrogen is really, it's not going to do what we think of for bone protection and heart and hot flash and what have you. And when we take systemic estrogen, even though it is a higher dose, there are some people who may notice some aid to things like incontinence, but usually we need it more on those exact tissues. What we put as systemically has to go to a whole bunch of areas, and it's typically not enough once it reaches the vagina and the genital, like our genitals and around our bladder, is typically not enough to really address the symptoms of GSM, genital urinary syndrome of menopause.
So applying to the tissues is where we're going to have the most effect on the integrity of the vaginal wall. And so what about, how do we know that we don't have estrogen in the tissues? Okay, so we're in menopause, we get our blood labs done. Oh my God, you have no estrogen. Here, take some estrogen. How do we know that the tissues don't have estrogen? How do we know it isn't just I guess because you add the estrogen and then the person feels better. And so then it's like, there's our answer. Is that what we're doing with dosing per estrogen at the vagina?
There's no testing specific to the vagina. But again, the statistics I shared earlier, upwards of 80% of women will experience one or more symptoms of GSM. One of the main reasons why I'm pretty bullish on vaginal estrogen is a reduction in the risk of UTIs. So part of the role of estrogen is to help maintain the healthy bacteria, the lactobacillus, within the vagina. In a low estrogen state, the pH of our vagina changes. We become less acidic, more prone to infection, in many part because lactobacillus doesn't have estrogen to help keep it robust. So the increased risk of UTIs post menopause skyrockets. And the other challenge with that is that if a doctor is not educated in GSM, in hormone therapy, in menopause care, they will prescribe antibiotic versus antibiotic and another antibiotic and another antibiotic. And if we just gave that person some estrogen, it could make a world of difference. So UTI risk reduction is a huge reason for me, because UTIs you become antibiotic resistant. They can become septic. It's life-threatening. It literally is life-threatening. The other thing is, again, that's a big reason. All of the symptoms. So the genital changes. So the thinning, the drying of the tissue, itching, burning, redness, inflammation, the changes to sex. So painful sex, ripping, bleeding with sex, the urinary urgency, frequency, overactive bladder symptoms, stress urinary incontinence. Those are all things, again, that people may have had those symptoms along the way. So they're just kind of like, well, it's not low estrogen. And they don't think of it as now being a reason why estrogen would help, if that makes sense.
Yeah.
So it's one thing to, I don't believe in kind of where we started. I don't believe in waiting until we have one or some of these symptoms. When you look at the statistics, when you look at the research about the safety and efficacy of vaginal estrogen, to me, it is a no-brainer that it should be just standard practice. Once have reached your menopause, this is now something that we use to prevent UTIs, to prevent urinary incontinence, to prevent the changes to the external genitalia. So I don't think we need a test to tell us that we have a dry vagina or that we have incontinence or that it's just step in. It is, I would argue, almost no risk intervention, whereas we can prevent a lot of other very great risks.
Now, do you think that estrogen without progesterone is okay? To be adding estrogen?
I get this all the time, and my wording is, whether or not you have so people have heard if you have a uterus and you're taking estrogen, you need progesterone to prevent the thickening, abnormal thickening of the uterine lining. That's true systemically. Vaginally, again, it's so low dose, it's really staying and acting locally. Very little, if any, is getting elsewhere. You don't need progesterone, even if you have a uterus and you are using just vaginal estrogen. That doesn't mean that you would not benefit from progesterone. So many people who have had a hysterectomy, and now I'm moving over into the systemic side, they're denied progesterone or said, "Oh, you don't need it because you don't have a uterus." And progesterone does far more, as I'm sure you would agree, than just protect the lining of the uterus. So I would suggest you still benefit. There's evidence from bone health. There's evidence for breast health with progesterone. It's our calming, feel-good hormone. So if you are using vaginal estrogen, whether you have a uterus or not, you don't need progesterone, but you would still, depending on your phase of life, you would still benefit from progesterone.
I definitely feel like some women, like myself, they're just some women don't do good things with their estrogen. Some women will push it down unhealthy pathways. And so
With systemic, I don't see that happening with vaginal
right. I
estrogen.
guess this is where I think the big argument lies, which is that how can a hormone that you put onto your skin, especially vaginally, where the mucosal lining is so incredibly thin, I mean, it passes straight into the bloodstream. And so you're saying, and so many experts, Dr. Rosensweet, so many people say this, that it stays locally, but because the dose is so minute. But I mean, the potency of estrogen is so compared to, you need 600 picograms or whatever the measurement is of progesterone to equal one estrogen. And you put that in me, you can take phytoestrogens in me and I will grow things, or I used to. And so I see women in the group, and we are a bunch of outliers in my group, I'll give you that for sure, is that, we have women who have been on estrogen for a long time, only estrogen exogenously. You probably don't know this, but I work for Ona's Natural, which is a plant-based hormone support company. I basically do their outreach, their marketing and everything, and we sell estrogen. So I'm definitely game for it. I'm never going to say don't ever do it and it'll kill you. But I just feel like the message of everyone should do it and it's okay and it's safe no matter what, I feel like is not entirely accurate for everybody. And I might get back to you in a year and be like, dude, I'm on the estrogen now because but so far I feel like there are women who definitely, and in the group of my outliers who we see all the time, who are like, dealing with breast cancer now or dealing with, different types of estrogenic driven issues. Now, there could be a lot of other things. There could be xenoestrogen load. There could be a lot, especially stagnation at the liver with genetic mutations and all kinds of stuff, mold, all those things that can throw a wrench in the spokes. But I guess I'm arriving at a place where it's like I'm open to it. I want to learn more. I want to be knowledgeable. Like you said, I want to know everything before I go into it, because I'm getting to that place where I might need it. But I also know there's a lot of women in the group who are like just using it. Like Dr. Felice Gersh is like, just go bonkers with it. Do it. Go ahead, use it as much as you need to use it. Like you don't want to have, and Dr. Rosensweet said, who cares if you have, estrogen in your tissues? If I can help my patient feel better, that's what I care about. I'm like, yeah, but what if we're helping her have great sex and now she's got this lymph issue under her right armpit and her breasts are cystic and fibrotic and what? I don't know.
I know where you're going. I hear what you're saying. I think the evidence to me is compelling. It is safe for people with, like, there is no recurrence with breast cancer. There are no links to cancers of any kind with local vaginal estrogen. There are estriol and estradiol. Estradiol is typically what is in most studies. Estriol is if somebody feels like they are sensitive, they may want to start with estriol first, given that it is less potent, it's more anti-inflammatory. But I understand what you're saying. The research that I have done, all of the experts that I follow, including, yes, I follow Felice and Dr. Rosensweet. I also follow Kelly Casperson and Rachel Rubin and Dr. Corrine Mann, like a lot of other people talking about estrogen, talking about the research as it pertains to cancer. In my mind, and based on the evidence that I have seen, it is more compelling to recommend it for pretty much everybody than to not and wait for there to be issues. Not to say that it's too late and you can't, like if you do start to experience symptoms and then decide that now it's time. And also, I wrote an article called Vaginal Estrogen and Other Helpful Therapies for Vaginal Dryness. I use the term vaginal dryness because that's what a lot of people search for.
Mm-hmm.
In that article, I provide oodles of research. I also provide other therapies that people can try if they still feel uncomfortable based on the literature or their situation about estrogen, or if they react. There are some people that may not tolerate it, and that happens. I wouldn't say it's super common, but it does happen.
It's very common in my group. It's all too common, which is one of the reasons why I'm like, okay, let's just buyer beware here. You know, if you are that person, let's use it with progesterone. Let's check every, 6 weeks or, every 3 months. Let's check and make sure that you're not taking that little bit of estrogen and doing something bad with it.
Yeah, and so Dutch testing is something that I look at. I don't use the Dutch test myself. I'm not a prescriber or a doctor. I use it personally. I recommend it to people to look at how you are metabolizing your hormones. So that's a way for somebody, they could do the Dutch test with their vaginal estrogen to see if that is having any influence on their levels.
Yeah.
Yeah. So I do personally still, though, based on evidence, if that estrogen is the gold standard. There are some people that can't. So in that article, it shares other things that they can be doing: vaginal DHEA, sea buckthorn oil, hyaluronic acid, all the other things. But that is not going to.
Sorry, is that art? Okay.
Vagina Coach.
I'm going to link that in the show notes for everybody too.
Yeah. But that's not, the hyaluronic acid will help with the dryness, itchy, burning, maybe. It won't help with the incontinence piece. It won't help with the change to the pH piece.
Right.
So to me, it's not as robust in its tissue support and all the things that it does. I absolutely recommend hyaluronic acid. I recommend estrogen. I call it ELM, estrogen, lubricant, moisturizer. We need those three. They don't replace one another. They all have their own roles. But if somebody is sensitive to estrogen, there's DHEA that I'm a big fan of, Interosa or Julva from Dr. Anna Kabeka. And we are all, at the end of the day, unique individuals. And what works for most still may not work for
all. Yeah.
All. Yeah.
And so you don't ever recommend progesterone to try that first for even for lubricant or for vaginal dryness. That's not something you go to first at all.
Again, I'm not a prescriber, so I can talk about it, but it's not something. Typically my recommendation first would be estrogen or moisturizer, DHEA.
Gotcha. Okay. Well, we packed it all in for sure. Is there anything else you'd like to throw my way to my peeps?
I guess I always usually end off saying, I've said it already, see a pelvic floor physical therapist once a year. Pelvic floor muscle training, we think of Kegels as the only thing that we're supposed to be doing. And we need so much more than just Kegels. We need a whole body approach, train the pelvic floor dynamically. And it's not something that we just do to fix a problem and then we're fine. Just like we brush and floss, we don't stop when the dentist says we don't have any issues. We keep going. So pelvic floor muscle training is something that we would benefit from for life.
Love it. And then the football is not a Nerf football, right? It's an actual inflatable football.
It's not I'm just trying to see if I had it here to show you. It's not a leather bound NFL football. This was a kid's toy football.
A kid's toy that is inflatable. because
It's
that's in the
inflatable
era.
and it was not fully inflated. And it's so funny that post, like I literally was at the end of a workout one day and I needed to do some pelvic release and I'm like, here's my football. And I've done stuff with a
Everybody.
pool noodle and a rolled up towel. And I just like, I might as well film it. And oh my gosh, I couldn't believe how many comments I had on that post. It was
I'm
quite
sure
funny.
Amazon got more football orders than
Yeah.
they ever got. And if you're listening to this, you have to follow her Instagram, Vagina Coach, in order to know what we're talking about. And it's
Yeah.
super important. And get your football and your pool noodle now. Okay, I hope you enjoyed that as much as I did. I learned so much more than I ever thought I would learn. I mean, I just didn't realize how much pelvic floor health has so much to do with back pain, spinal health, everything, probably leg pain, all of it, sciatica. What she described is so integral to our structural health. And of course, we got into the hormones. I saved that bit for last. And, the reality is, I just don't know that I'm ever going to agree with someone who says that estrogen is totally safe and that it stays local. It's just not going to be something that I agree with. Not when I personally have had my own experiences with taking very small amounts of estradiol vaginally and immediately within 24 hours having swollen cystic breasts and fibrotic issues, denser breasts from taking vaginal estrogen. And I am certainly not the only one. We might be outliers, but just come into the group. Just come into the group and see how many women have negative reactions. Yeah, their vaginal atrophy eases up. Yeah, their painful sex eases up. And maybe they have, some less joint pain. All those things are amazing. And then they've got a list of things: insomnia, the weight gain, the moodiness, all of these things. And so I'm just never going to be, I don't think, I could eat my hat, but I'm just never going to be the person that says estrogen is totally safe and every woman needs to get on it in perimenopause or menopause. I'm just never going to be that person. I'm going to be a person that says buyer beware, check it, test it, see how you feel. Don't ignore everything else going on when you take it. So that's for all of you that were waiting and looking to see what would happen with that discussion. I think it was very helpful. Again, neither of us are doctors, so neither of us are telling you what to do. She is a wise woman that has a lot of fantastic information that I certainly learned a lot from. So I'm super happy to have introduced you guys to her if you didn't already know of her. And definitely check out the show notes because I attached that blog that she mentioned as well as her Between Two Lips podcast. She also mentioned when we stopped recording to go to Google if you're looking for a pelvic floor therapist and look for a pelvic floor therapist near you. But also there's the pelvicglobal.com and apta.org in Canada. But she said you're more likely to find answers through Google to find a pelvic floor specialist. And then she gives all kinds of exercises and fun stuff to do on her actual Instagram. And I think she is on YouTube as well. So I wanted to talk quickly about this new program that I am doing with Jake Miner. He and I started, we had this long talk about the first coaching program I'm going to do in the group. What's it going to be? And I really enjoy his teaching. I enjoy what he puts out there. I think he's wonderful at explaining things, really, really personable guy and knowledgeable. Just thinking about all the women in the group who are always talking about, sexual dysfunction, sexual issues, intimacy issues, libido, vaginal dryness, a lot of the things that Kim and I just talked about. And also the men, their husbands, and testosterone, low T, and low drive, or low drive for you and high for him, or vice versa. And I thought, Valentine's Day is coming up. I thought it'd be a good thing to do this 6-week course that's going to basically offer, some help. Where I'll just read this because it's easier. Whether you're struggling with low energy, stress, or intimacy challenges, this program will help you and your partner reset, reconnect, and revitalize through pro-metabolic nutrition, lifestyle shifts, and intimacy enhancing strategies. It starts on Valentine's Day. We only have 25, well, it's not 25 anymore, 25 spots, 1 class per week, 2-hour live sessions, plus a bonus tech class on macro counting and using a chronometer. which you don't have to take, but it's available. And then we have an exclusive private Facebook group for ongoing support and discussion. So if things don't get answered in that coaching class, you can log on to the group and say, hey guys, this question didn't get answered or whatever. And, both of us will be in there, including a few moderators to be able to help you out. And you can also post your labs in that group. Even though that particular class isn't geared towards that, you can still post your labs in that group and get some input from those of us who can give input. And so what you'll get pro-metabolic nutrition, learning to fuel your body for hormone balance, hormone optimization, understanding key hormones that affect your relationship, intimacy and libido support, strategies to enhance connection and sexual vitality. This is going to be a really good one because yes, you can take this class if you're single. It's the same price though for 2 people or 1 person. But we're going to touch on the emotional component to, when we're in relationships for a long time and when we're going through perimenopause or menopause, or just in a relationship for a long time and you're not going through perimenopause, you're still in your 30s or whatever. And what that does and how you can prep for how you can prep for perimenopause, how you can start to anticipate the changes in your body, both of you, so you're anticipating those changes. And let me tell you, it's not just women. Men go through this too, and it would best serve them to understand what's happening to their bodies and to understand what's happening to their spouse or their partner's body. So also metabolic health and stress resilience. Hello, that's something that I finally have a handle on. Stress resilience, incredible. Exclusive Q&A personalized guidance, get expert insights from Jake and I, and then the private Facebook group. If you're not part of our estrogen dominant support group, you should join it because if you join it, you'll get a coupon and it'll be $50 off. So to learn more, just go into the show notes and click on the couples hormone reset and you can learn more. Thank you guys so much. And I hope to see you in that class. This is one of many that I will be teaching. I think the one after that or alongside that is going to actually be liver detoxification. I know people are chomping at the bit to take that course. So I'm prepping it now and it'll be available very soon. All right, friends, thanks for joining.
Kiss, oh what bliss, it weakens the heart but it strengthens the soul.